My name is Matt Winterstein. I'm a psychologist at Thomas Jefferson University in the Department of Psychiatry and Human Behavior. And so the focus of what I'm going to be talking about this morning is really, you've done some screening. Maybe there was a positive result in terms of they've been thinking about suicide, or they've got a lot of risk factors for it. Sort of what's the next step? Why do we do more beyond that, and how do we do that? So here's my disclosures, none of which has anything financially bearing on what we're talking about here today. Talk a little bit about epidemiology, risk factors, interviewing skills. My hope is that I'm going to cover a little bit of the epidemiology for suicide in youth, but I don't want to talk about that a whole lot. I think it's far more important to do the clinical piece of this than it is to go in and collect all the data and talk about that information for you guys. So I'm going to start here showing this wonderful slide that CDC puts out every single year. And you can focus on a couple of different age groups, but we're most interested here in the 10 to 14-year-old age group and the 15 to 24-year-old age group. And what you can see on here is that within each of those groups, suicide is the third leading cause of death. In the 15 to 24-year-old age group in 2010, there was 4,600 deaths by suicide in this country alone. And a couple interesting pieces about this. Historically, if you'd seen the 2009 data and 2008 data, et cetera, we're actually closing that gap between homicide and suicide rather rapidly. There's only about 78 deaths that separated them in 2010. In 2009, that was closer to 300, almost 400. So that gap is getting much, much smaller. And actually, if you aggregate these two groups together and you just combine them, suicide is actually the second leading cause of death across these groups. And when I work with primary care folks, I like to emphasize a couple of points about this. The first is that if you actually look at all these white cells that are on here, so those of you that are in medicine and nursing, physician assistants, NPs, all the other medical nursing fields out here, these white cells are a good part of what you learned about in school, right? And these are all the different diseases that exist. And the blue cells up here, the unintentional injury, are the things that show up in emergency medicine. They typically don't show up in primary care, and certainly homicide isn't showing up in primary care. So if you think about all the stuff that you learned about in school, most of it are these white cells that show up on the screen. Well, if you add the 7 leading non-injury-based medical conditions combined in that 15 to 24-year-old age group, it doesn't even come close to how many suicides occurred in that single year. So the point being is that for your adolescent young adult population, you've got a greater chance of having a patient die by suicide than many of the things that you learned about in school for that age group. And sort of the other point that goes along with this, suicide is actually the second leading cause of death for the first half of Americans' lives. So it's an important issue, and it shows up in primary care. You will see a lot more suicidal people if you work in primary care than I'm ever going to see as a psychologist. It's just that they don't walk in and tell you necessarily that's why they're there. So part of the idea is what kind of questions can we ask them and how can we get that information out? So looking at, again, the national problem, there was 38,000 suicides in 2010, gives us a rate of about 12.4 per 100,000 in this country. And that's, again, looking at adults and youth. But when we look at just youth, over 4,800, almost 4,900 suicides. It amounts to about one young person every 1 hour and 47 minutes. And you can think about how much time we're going to be sitting in this room here for those of you today or those of you that are online. That's a few people just in this time that we're sitting here. I already mentioned that third point there. And even if you start thinking about younger kids, I had actually spent about 5 years at CHOP before moving down the street, and was here at the time when JACO came through and said, listen, for every single youth that's being treated for a behavioral emotional problem, we need to do a suicide screening. We put together a whole group of people because the conversation was, how young do we go? You know, in a children's hospital, at what point do we start asking them these questions? And we had to fall back on the data and found that, at least in Pennsylvania, under the age of 10, there weren't too many suicides. And we felt like, all right, 10 was a logical place we could start at that point in time. But even when you look under these 15-year-olds, 274 kids in 1 year. It's 274 little kids in 1 year. That's quite a few. So how do these rates change over time? As you can see here, when you start entering sort of early adolescence, those rates start to escalate, and we see a peak around just post-high school, early college age youth. If we extended this trajectory a bit further, what we'd see is that there becomes sort of a decline In the 30s, you see another increase. In the 40s, you see another decline after that. And in the mid to late 60s, there's a slow but steady increase that continues throughout. I mentioned this briefly. My point I like to make about this slide is that suicide doesn't discriminate. So I could show you all these statistics about which groups or populations are maybe at the highest risk for suicide, but that doesn't make a bit of difference in terms of who's sitting in front of you. The fact of the matter is that African American women, who may be the lowest group on here in terms of rates, they die by suicide as well. I can't use that as a thought to say, oh, okay, well, I'm not as concerned about you. No, we need to focus on people individually, and that's really what this is about. All right, so the guy's convinced you, or maybe he'll convince you this afternoon. We got to use a screening tool. We come in and ask some questions. It's kind of, listen, I can talk about it from both sides, but what I'll tell you, it's kind of nice in the sense that you have the opportunity to ask some of the questions that are difficult to ask, and it gets done before you actually have to do it yourself, and all you're doing is reviewing and then following up on that kind of stuff. I mean, you have to do the follow-up piece. But so let's say you've done something and the questions have already been asked. Now somebody's endorsed something. What in the world do I do at this point in time? Because sometimes it's easy to say, okay, well, they endorsed this question, so I'm going to, was that Sarah that was over here a second ago? Where'd you go? Hey, I'm going to call in the social worker, and he or she's going to take care of this, and they're going to deal with this. And it's nice that we have social workers here that work in a lot of larger primary care practices. That's not the model that exists in the world outside of, multi-billion-dollar industry. But anyway, what do you do? They've answered some questions. What do you do about this? So obviously, we need to ask some more questions. And there's a couple challenges to this. Even if you ask them explicitly, are you having thoughts of suicide on a sheet of paper, and they say yes to that, the problem is the data that exists out there doesn't necessarily say that by saying that, they're going to go home and do something about this, which is a real dilemma in the field, because it ultimately comes down to we need to collect more information to determine what level of risk somebody might actually be at. The other problem that comes up is that the question isn't always, are you having thoughts of killing yourself? Are you having thoughts of suicide? Screening tools have multiple different ways of asking questions, and the truth is we may not, in fact, have a clue what they just said yes to, and they might not even know exactly what they said yes to. So here's a few of the common questions that show up on instruments that get used in a variety of settings. It's not just primary care. We use these in psychology and psychiatry sometimes as well. So somebody says, desire to hurt yourself, yes or no, or rate your desire to hurt yourself on some sort of scale, or have you ever hurt yourself on purpose, yes or no, or the PHQ-9, which is probably the most widely used depression screening tool in primary care. The question is, thoughts of being better off dead or of wanting to hurt yourself. What part of that question says, are you thinking about killing yourself? It actually doesn't. Nor do these other questions, which show up on screening tools quite a bit. And so the challenge that we run into is that the way that we ask the question gives us certain information, and we're missing some things if we assume things based on what they put there. So desire to hurt yourself, I don't know if that means that this person's really thinking about killing themselves, or if this is somebody who has engaged in self-injurious behavior before, perhaps, and that's sort of their technique and strategy to manage, some stressful situations that occur in their life. If I assume that it means one thing, then I'm going to take one path. If I assume it means something else, I'm going to take another path. The problem is I might be going down the wrong path. So we need to ask more questions. So even if we're using screening tools, people say yes to questions, we need to follow up with those questions to really get a sense as to what they in fact mean. So the other thing that happens sometimes, as I mentioned before, is I do the screening, you've endorsed something, I have to figure out what to do with it afterwards. I'm fortunate enough, I do have somebody else here who can talk to you about this, and so every time somebody endorses question 6, or let's do PHQ-9, right? Every time someone endorses highly question 9 on the PHQ-9, I'm going to have them talk to this other person. It's a little bit problematic. I mean, it's nice, perhaps, from your perspective. It's like, okay, this is somebody else's problem, and they can deal with this now. But the truth is, how far do we go with this? We actually looked at this in a study that we did here at CHOP several years ago, where we started standardizing the questions that we were asking youth in EPIC in primary care. We put the questions straight in there because ahead of that, the questions were something like, it used the SHADS mnemonic, and there was this S for suicidality. And if you looked at the de-identified data, what you found in there was a whole bunch of blank cells. Now, I don't know if that means the questions weren't being asked, or if the questions, or some question was being asked, but the answer was no, perhaps, and they just skipped over the cell or whatever it might be. So we kind of went in and said, listen, let's help you out a little bit. So we added a couple of questions that everybody got. An endorsement of that then, created a couple of other questions that would emerge as well. But the default, because you know how it works, right? In these electronic medical record systems, you go through the psychosocial. If the answer is no to everything, then you can hit default all, and suddenly everything says no, 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 and you don't have to go in there and fix it every single time. Well, we made the default did not ask. Nobody wants did not ask to be the thing that sits on the medical record about suicide risk, right? So you had to go back and manually change it from did not ask to no, if in fact the answer was no, and by the time you did that, you might as well have just asked the question. So we changed it so that people were being asked the actual question of what was going on. And by doing this, we were focused on a couple of clinics, and one of which was referring down here to the hospital for psychiatric consultation for the kids that they were concerned about. And we thought, all right, it'd be really interesting to see what happens to these kids in terms of what they endorse. And if we go in and do some education with the providers there, we introduce a more specific screening approach to what's going on. And, oh, by the way, it didn't hurt the fact that we were running a clinical trial at the time where a guy was running a family therapy study and they could get free treatment if, in fact, they qualified for that. That didn't hurt either. We went in and said, what in the world happens to this? So we looked at these kids before and we looked at these kids after this intervention and found that we decreased significantly the number of youth that came from this one practice down to the emergency room to get screened because the providers felt like they could handle it. They were getting better information about what was going on. And what they realized, a lot of these kids probably didn't need to be hospitalized. Prior to doing this intervention, it was something like about 50% of the kids who got referred down to the emergency department were getting hospitalized. After we did this intervention, just about every kid that actually made it down to the emergency department got hospitalized because the right kids were coming down here to be assessed to go into the hospital. So if the practice is, you answer yes to this question, I'm going to send you to go talk to somebody else, we run into a problem of they may not need somebody else necessarily. They may not need that higher level of care. Have you sat in the emergency department for 8 or 9 or 10 or 15 hours before? And imagine if what you're sitting in there thinking about is imagine being suicidal or having thoughts of suicide, right? And here we send these kids to the crisis center, where we send them to an emergency department where they can get evaluated. If we haven't asked enough questions, they're sitting there anyway for 8, 9, 10, sometimes longer hours. And through the process of this, they're thinking to themselves, what in the world is going to happen to me next? And for a teenager who's never had any experience with psychiatric hospitalization, their version of it's what I've seen on television or what I've seen in movies. If they're fortunate or unfortunate enough to have a peer who's been through this, they might have some better information, but they see padded cells, they see straitjackets, and they see getting doped up on a bunch of medicine via shots, right? And we know that at least 2 out of those 3 things are typically not happening with a great deal of frequency. But they don't know that. And so they're sitting there for 8 hours, and what in the world am I going to do during those 8 hours other than figure out how do I get out of this situation? So they show up in the emergency department, they get evaluated there, and they're going, I have no idea what that person was thinking about sending me down here. I didn't say that. We corrected that problem too by having them do some screening in primary care, and then when they in fact endorsed some of those things, we had them actually sign what they had said and sent it with them to the emergency department. So when they showed up there was no doubt that they had actually said those things. And they had to talk about it. Now, they still might have thought that they've changed their mind in the last couple of hours. But the point is, there's some secondary trauma that can go on in there. And then the other piece of it, what in the world does it do to the provider-patient relationship? So what you're saying is, when I tell you something difficult about me, you can't talk to me about it, and you're going to send me off to somebody else. So when other things come in my life that might be difficult, I can't talk to you about it, or you're going to send me to go talk to somebody else about it. So we want to be that person that's available to do that. So assessing further is important because we have to make sure that we're doing the best care that we can for our patients. And of course, the other piece of all of this is we're not just looking for risk factors, warning signs, and so on and so forth. We want to look at these protective factors too, because we want to do something helpful for people. We want them to go towards things that are good for them. And so we want to utilize the protective factors in terms of helping to think about what kind of interventions can take place. So I want to talk briefly about psychiatric comorbidities, and I split them up into two groups intentionally. The first is diagnoses, and the second is symptoms, because depending on the literature and how you're looking at it, sometimes they're looking at a diagnosis and sometimes they're looking at a symptom. And I spent a little while trying to think about how do I express the diagnosis part, like what increases somebody's risk for suicide. And not to be too simplistic about it, but if you open up the DSM-5 and you point to any page, that increases somebody's risk for suicide as opposed to not opening up that book for anybody. And the data actually supports that. David Goldston has been doing some great work down at Duke for a number of years where he's tracked youth after hospitalization, after a suicide attempt for a number of years, and basically found that, pick a diagnosis, for the most part, most psychiatric diagnoses were related to an increase in risk for suicide. And that strength of the relationship actually got stronger as the kids got older. So that's my simple version of diagnoses, right? If you have one. Now there's certainly, you can look at major depressive disorder, you can look at bipolar disorder. There's data out there on eating disorders, there's data out there on schizophrenia, borderline personality disorder. Those are sort of the big five that Thomas Joyner talks about. But there are certainly many others that exist. And we've seen a lot of anxiety disorders through some of the work that we've done with youth as well. So let's get down to the level of symptoms. I kind of break it into two different groups. You have sort of your individually based symptoms and you have your family-based symptoms. Guy kind of hinted at some of the things that are on the right column in front of you. But if we look at the left side, you've got your alcohol use and abuse. And sometimes in youth, it's interesting, how do you ask a teenager about alcohol and drugs in a primary care setting, depending on where they go to school? The question is not, do you use alcohol or drugs? The question is, tell me about your alcohol and drug use. Because those that are not using will tell you that they're not using. We don't want to normalize it as that everybody should be doing this, so tell me about how often you're doing this. But it's a stigmatized type question. The kids don't talk to their parents about this often, and so if we ask them, do you do this? The answer is going to be no most of the time, when sometimes, in fact, the answer is yes. But the point is we see an increase in alcohol use, or we see people starting to use or abuse alcohol when they haven't been doing those things before. Hopelessness is another construct that goes in there. There's been a lot of data kind of looking at depression as it relates to suicidal ideation and attempts, and sort of that moderating role or the moderating role that depression might play between hopelessness and suicidal ideation. Perception of low self-worth and low self-esteem, and people feeling like they're not good enough in some way. This sense of things are never going to get any better for me, and I'm no good at this, I can't do that very well. Impulsivity is an interesting one, and the data is somewhat conflictual. It goes back and forth a little bit, but by and large, I think clinically the perspective is, how do people cope with problems generally in their lives, and how have they done this before, because this may be the mechanism by which they're going to use in the future. We know that most people who don't attempt suicide it's not that they've never had that thought and then suddenly they have that thought and then they engage in the behavior that quickly. Oftentimes the thought has existed, the behavior may be more impulsive, but the thought maybe has been there for quite some time. And then insomnia, which I don't think, David, you're going to be talking about, but we know there's a lot of literature are you talking about insomnia? Okay, just put it on the docket, right? There's a lot of literature anyway that's out there these days that are really looking at insomnia. We're seeing quite a bit of insomnia in youth that are making significant suicide attempts and are dying by suicide. So on the family side of it, guys talked about family communication, parental psychopathology. I'll get to a slide that focuses more directly on parent suicide, family conflict and stress, and sort of the attachment model of how do we address some of these things that Guy mentioned. We talked about abuse. I think the abuse thing is an interesting thing, as we did a study here in Philadelphia several years ago and found that, I forget, about 60% of the youth that came through this study, maybe about 67 youth, they all entered this study because they were having significant persistent suicidal ideation and depressed mood. And over half of them had made a suicide attempt before, and over half of that group had made multiple suicide attempts before. Within that population, well over 60% of them had indicated some form of abuse in their life, not necessarily meeting the criteria for like post-traumatic stress disorder, but having multiple experiences, so they couldn't really link it to one thing. And then, of course, family structure changes. It isn't necessarily a risk factor for suicide, but you got to think about it from the perspective of the 15, 16-year-old who's been living in a community with a set of peers that they've had for a long time, and suddenly we're going to uproot and put them in another school somewhere, in another place, and That's a difficult process. Think about the last time you changed a job. Imagine doing that when you're 15 years old with 1,000 or 2,000 other people that know each other really well, and you're the person they don't. So looking at parent suicide as a risk factor, and I'm not getting into some of David Brent's work necessarily, but he's done a lot of work kind of in this area as well. Kids who have had parents die by suicide, their risk for suicide increases at a rate that's significantly greater than those who have not. There was a great study that was done somewhere in Scandinavia. They found that youth who had a father die by suicide were twice as likely as their peers to die by suicide. Had their mother died by suicide, they're 5 times as likely. So if you're working with somebody and you're talking to them about suicide, it's, getting a family history is not a bad thing. We want to do this kind of stuff anyway, but having that bit of knowledge really helps increase our awareness of what's going on. So kind of getting at that issue of suicidal ideation and behavior, there was a study where they were looking at kids. They started following them, I believe, around 12 or 13, followed them to the age of 29, and it was boys. And what they found is by the age of 20, nearly half of, and this was a normal sample. This is not some psychiatric group that they were pulling in and saying, listen, how much do you think about suicide? And within a normal sample, about half of them by the age of 20 had endorsed on a yearly evaluation. Half of them had said they'd had some thoughts of suicide. 57% indicated at some point in time over those years, by the age of 29, they'd had suicidal thoughts. And the more striking piece is that more than half of the people who eventually are going to report suicidal thoughts have said so by the age of 14, and the highest age, or the rate where you had, or the age where you had the highest prevalence rate was age 13. So it's prevalent. And then people say, well, what's the big deal? So people have these kinds of thoughts from time to time. And if you look at the old data, we don't know if what they meant were they suicidal, or we've kind of separated it from what we're calling morbid ideation these days. And so that thought of people would be better off without me. If I didn't wake up tomorrow, that would be okay. But it's not really tied in with this idea that I want to do something about it. We've separated that, but in the past, they've been all lumped together. So you're looking at these rates of 20%, 25% of youth who've had thoughts of suicide. So what's the big deal, right? I mean, they deal with this, they get older, everything's going to be okay. Well, there's a great study that looked at 15-year-olds that had suicidal ideation, not necessarily attempts, but suicidal ideation, and looked at them again 15 years later at age 30. They were twice as likely as those who didn't have suicidal ideation at 15 to have an Axis I psychiatric diagnosis. They were 12 times more likely than that group that didn't have suicidal ideation at 15 to have made a suicide attempt. And they were 15 times more likely to have had suicidal ideation in the past 4 years. So in other words, when I'm 15, if I'm having thoughts of suicide, I am 15 times more likely than a peer who hasn't had that to have thoughts of suicide when I'm in my late 20s. It's a big deal. So I want to talk about very quickly, talk about two kind of hot topics that are out there. I think the conclusion, interestingly, is somewhat similar to that. So when we think about sexual minority youth, we think about bullying. Bullying is sort of that, at least for the last couple of years, has really been a hot topic in this area. But focusing on the LGBT youth, LGBTQ youth, there's some data that suggests that gay and bisexual youth are up to 7 times more likely to have attempted suicide than their non-LGB youth. And there's some data that actually shows that the suicide attempts that they're making are more serious based on some of the initial findings when it comes to both the intent to end their lives as well as the lethality of the behavior that's going on. But of course, the point that needs to be made is that being gay, being bisexual, doesn't necessarily make you suicidal. There's plenty of people that are gay, lesbian, bisexual, transgender that haven't even thought about suicide. And so the issue isn't so much the sexual identity, but more about gender nonconformity, low family connectedness, sense of family rejection. In the work that we were doing very early in this family therapy study, we found that it was like 33% of these youth that we started out with were identifying as LGBT youth. And when you would hear their narratives about it, more often than not, it was this sense of, I'm going to be rejected if I come out to my parents. If I tell other people, I'm going to get rejected. And we worked with them in therapy, and in many cases, they came out and told their parents about it, and surprise, surprise, their parents didn't kick them out of the house. But it's this sense, this belief that goes along with it, that if it's being fueled in some way through schools, being fueled by society, those kinds of things can then turn into the sense of, I'm rejected, I don't belong, I'm no good. Unsafe schools, another thing, victimization, stigma, the other pieces. Now, bullying as of today, unless something's been published in the last couple of hours, there's no direct empirical link that says that if you're bullied, you're going to die by suicide. There is data out there that says that both victims as well as perpetrators of bullying are at higher risk for suicide and suicidal behavior than those that are not. And some data that actually suggest that if you do both of those things, so I bully people and I get bullied, I may be at higher risk than either of the other two groups together. So let's move on to the assessment. This is more the clinical piece of it. Hopefully that was a good overview of some information that would be useful for you. So these are just sort of some key points when it comes to working with youth, and those of you that are in some of the practices around here that I've come talk to before, you may have heard this already, so I apologize, but it's just some point. A lot of this has to do with adolescence. It's not necessarily that they're suicidal, it's just that they're adolescents. So when you're asking about suicidal thoughts, the person that sits there for a while and thinks about it then comes back and says, no, well, that's interesting. You know, what's the pause for? No, not really is a response that you get a lot. Well, the interesting piece of it is the not really part of it, right? So not really means that maybe some. The issue that happens, though, is it may be that I've had these thoughts. It may be that I don't think about them very often, or they're fleeting thoughts and they go away. And maybe they don't trouble me too much, or at least not too often. And right now I'm not thinking about it. And so you're asking me about this, and I'm thinking, well, if I tell you yes, but then I tell you that it just sort of comes and goes, you're going to think that's not all that important. We don't need to do anything about it. So I'm going to say, no, not really. No, not really is interesting. So I want to know more information about that. Obviously, when we work with anybody, adults or kids, we pay attention to body language. The people that aren't looking at you is important. I'm supposed to stand behind this podium or I give you the little foot shake kind of thing. You ever had somebody sit across from you and you see the foot start going like this, right? Indicator for anxiety, something's going on, they're thinking about something. You can kind of see the thoughts going through their head, but you can't read them. Wouldn't it be great if we could do that? The other thing is that, you know, we're taught, and it's interesting what model and what your professional role is. As a psychologist, I'm generally taught not to sit there and take notes. It's just I learned from more of a psychodynamic perspective, and I wasn't going to sit there and take notes. But in other practices, and certainly in medicine and in nursing, if you don't take notes, you have a lot of extra work to do later on, right? So the tendency is to sit there and take notes. And I've actually seen people, and I've observed people sitting there kind of like this, computers over here, patients over here. So you've been thinking about suicide. And they're typing these notes in and stuff like that, which then feels terribly disconnected to the conversation that's going on. And the truth is, the importance of this conversation is so high, you're not going to forget what they said. It's time to put the notes down just for a minute. Let's focus. Let's talk about this. Because the fear is that this looks like I'm not interested in you. But this does. And we want to make every effort for people to feel like they're being heard, they're being validated for what it is that they're experiencing, what they're sharing with us. We can't look like we're uncomfortable. I've seen plenty of kids come through that start with me and say, I'm thinking about killing myself, or some of them come in and flat out say, I want to kill myself, I'm going to kill myself. I still get a little anxious each time that happens because I'm worried about this person. There's a lot of things that need to get done. But I want to listen and I want to be attuned to what's going on. If you don't have that experience, you see a lot more kids that are coming in for other reasons and then they show up and say that to you. Sometimes it's a bit frightening and it's a bit overwhelming. We can't let them see that we're frightened, that we're overwhelmed, that we're worried about this in some particular way, that it scares us too, because that doesn't help. People often ask, if I start asking about suicide in primary care, I've only got like 8 or 10 minutes to talk to them. If we have this conversation, it's going to go on for like 3 hours. Well, so like if I do this really quickly, then I can get it done really quickly. Well, the problem is the data actually shows, and certainly anecdotally we can tell you this, if you go really quick with somebody when they're feeling awful, you're going to end up spending more time with them than if you go slow, because they're going to get amped up too, and now you got to deal with that. So we don't want to hurry with our assessment. It's an important piece of the model. The conversation that they have with you in a primary care setting will actually dictate, I think, quite a bit as to whether or not they're going to come see somebody like me. Because if they can tell you about how they're feeling and they feel like you're listening to them and you can validate how they feel about it, when you say, hey, how would you feel about talking to somebody else about it and doing some of the stuff that Guy talked about in terms of engaging the family, If they've had that experience already, even on a small level with somebody that they trust and they care about, might they do that again? Who knows? There's no good data on that yet, but that might be a interesting study. So other things with adolescents, we've got to think about confidentiality. There's limits to what we can talk about and can't talk about, or what we're going to share and what we're not going to share. Sometimes kids say, certainly to their peers, they go, "Can I tell you a secret? You're not going to tell anybody about it." Well, we can't do that. At least not when it comes to suicide, right? If they feel comfortable enough telling me about their suicidal thoughts or behaviors they've engaged in or something like that, and I'm concerned about them, you better believe I'm going to talk to somebody about this. And they know it ahead of time. I even tell them, these are the limits of what we're going to talk about. And guess what? They still tell me that they're thinking about killing themselves. By telling them I might have to talk to somebody, it doesn't seem to shut them down from saying it. But they know that. They know we're going to have that conversation. You know what? And if they get mad at me for it and don't want to come back and see me for it, I can at least live with the feeling that they felt comfortable enough here talking to me about this, that they can feel comfortable again talking to somebody else about this. I try not to have that God complex where I'm the only person that can fix this kid in some particular way. Other people are out there. There's really good people that do good work. So if they can have that conversation with me, they can have it with somebody else. So if they're really mad at me and don't come back anymore, they'll connect with somebody else. Or they get really mad at you, and then they come back and realize that what you did was for their own good, and they say thank you and all that other good stuff. Sometimes it's helpful to talk about their fears of disclosing how they would feel. I kind of mentioned this before. Sometimes it's debunking sort of the myths. What are the things that they're worried about is going to happen if they tell you that they're having these thoughts of suicide? What do they think you're going to do? Having that conversation, even though it seems like a somewhat tangential conversation, can kind of reel people back into it. Guy talked about a team approach. There's two teams, at least in my mind there's two teams, there's probably more than two teams, but one team is you and the youth. If they did everything that you said for them to do, this would be wonderful, but if they could do all these things for themselves in the first place, they wouldn't be having this conversation with you right now. So we need to create a team around that family. So it's you as a provider and them as a family. And the second is, within your practice, unless you're a sole provider and you work by yourself, you don't have any staff there whatsoever. Usually there's at least one other person in the practice. You have a team there too. I'm worried about this person. I need to make some calls. Can you come sit in the room with them for a few minutes while I go do that and get in touch with somebody who can come and help us out, and so on and so forth. So you got to work together as a team. We always have to model hopefulness, even when we hear the most horrific stories that you can hear from kids. And if you haven't heard them, you're going to hear them. We hear horrible stories. We still have to model hopefulness. Things can get better. Even in the midst of tragedy, they can get better. And the last point I want to make is don't be afraid to say the word suicide. I gave a talk to a bunch of nurses and nurse practitioners several years ago here, in fact. And there's about 250 people in the room, and I asked them about halfway through, I said, turn to the person next to you. You're concerned that they might be suicidal. Ask them a question that you might ask them to see if you can get more information. So they went back and forth and did that. And I said, how many of you said the word suicide? Room of 250, right? And about 5 people raised their hand. I said, how many of you said kill yourself? And another 10 or 15 raised their hand. That seemed a little safer. And I said, how many of you said hurt yourself? And the other 225 or whatever hands went up in the room. If we can't say the word, they're not going to say it back to us, and they're not going to talk about it with us. So we have to be courageous enough to talk about the difficult things, just like we do when we talk to them about STDs and all that kinds of other stuff that we do. All right, so what are the questions? I've got 2 approaches to this. The first is sort of the basic, like how do you get there in the first place? So if you're in a primary care setting, what do you do? And the second is if you have a little bit more time with them, so you might be in the behavioral health field or happen to work in a practice where your billing is not contingent on you seeing 10 people an hour or whatever it might be, I've got another model for you too. Obviously, you can't go in and simply say, how you doing today? You having thoughts of suicide? That doesn't work. It doesn't work. It's uncomfortable for everybody, and you're never going to do it, and I'm glad that you wouldn't do it. So how do we get there? I only have a few minutes. Well, when you're doing the exam, you can ask them questions. You're probably doing this anyway. How are things going? That's a great way to just start a conversation. How's life? How are things at home, school, if they work? How's work going? We're trying to get a flavor for, is there anything that sort of sticks out other than, I'm doing really well, I'm on this team, I've got this going on, I have these friends, school's well, I'm getting A's and B's, C's and D's. They could even say I'm getting F's. That's interesting. But if they're comfortable with that conversation stuff, it's a different issue. But how they've been getting along with other people. How are things going at home? How are they getting along with their parents, their siblings? How are they getting along with their friends? there been any changes to like your peer group and stuff like that? With social media, these things change like in an instant. A couple minutes later, you're back in. But these things happen so rapidly these days, we have to ask people, how are things going in that context? A couple of years ago, I was in a meeting with, talking with folks about suicide prevention in primary care, and somebody asked, what's the one question you would ask somebody about that would give you some indication about suicide risk that we don't ask in primary care anyway? Number 4 up here is the question that I suggested, which is, how's your mood been lately? People don't ask that question in primary care, but if you start asking that question, you're going to get some really interesting answers that are going to be an indicator of, do we need to talk about this a little bit more? Alcohol and other drugs, I mentioned already. You know, once we start getting into this, we sort of get a feel for, are things going okay? And if things seem a little bit troubling at times, or there's some stuff that's going on, maybe we ask them some more questions. And so what are those kinds of things? Things so bad they're never going to get better. A lot of kids say, what do you think? That's usually a yes, but you want to get some more information about that. And then actually the 2 questions that we put into the screening program here several years ago, or 7 and 8 here. So, you know, in the past week, have you felt like life's not worth living? That's not, are you going to kill yourself? That's, have you felt like life's not worth living? And a lot of teenagers actually endorse that question. In fact, the state data that we get from the CDC suggests that almost 30% of high school students in Pennsylvania have said yes to that question. And then beyond that, have you ever wanted to kill yourself? This desire to kill yourself is somewhat predictive of an actual behavior. So have you ever had a desire? Have you wanted to kill yourself? Answering yes to that, we want to know more information. Have they prepared? What are they thinking about? What plans have they come across before? Have they ever tried to kill themselves before? What kind of attempts have they made? There's 1,000 questions you can ask about these kinds of things because we want to get details about it. But in a simple process, we want to go through that. And of course, we don't want to end the conversation with, tell me about the 6 other times that you tried to kill yourself, because it makes them feel really uncomfortable and unhappy. And at the end, that's not how we want to leave things. We want to know what keeps you going. What are the things that keep you alive right now? What are your reasons for living? And they talk about that. And then who can you talk to when you're feeling down? We make assumptions sometimes that they can have a conversation with a parent, a older brother or sister who's mature enough perhaps to have that kind of conversation. So not only do we ask them, who can you talk to about it, but the important question is it helpful? You know, can you talk to your mom about this? Yeah, I could talk to my mom about that. Well, everybody could talk to their mom about it, right? So is it helpful? Yeah, it's really helpful. She listens to what I have to say, you know, and she hears me. She doesn't tell me what I'm supposed to do about everything, but she listens. Okay, that's good. Other times the answer is she criticizes everything I say, and she's going to tell me what I'm supposed to do, and I really just want her to listen, and that's sort of, you know, kind of where Guy was, the education piece in terms of working the 2 of them together. But we want to end on this kind of hopeful, upbeat, tell me about what's going well for you, because we can use that in terms of our intervention. Now, if we have more time, you know, at that point in time, then it's sort of like, well, what do we do? So we're talking to them about, you know, how would you feel about talking to somebody else about this? We get more information. You know, we start working on making that referral to get them to have that conversation with somebody who can spend more time with them. You know, we're trying not to do psychotherapy in primary care. I know it happens sometimes, but we're trying not to do too much of that, but we're hopefully getting them connected with other people. And Guy this afternoon will probably talk a little bit about how, in this other project that we do, how do we actually help create that connection, because it's an important piece to which I don't have a whole lot of time to discuss. So let's say you're kind of that person that then receives this kid, right? You might be a social worker in a primary care practice. You might be that 1 or 2 psychologists, psychiatrists, psychiatric nurses who happen to go over to a primary care practice, you know, a couple hours a week, or what if you actually worked there? You know, I mean, these kinds of things. You know, what do you do beyond that? How do you get more information? And so kind of building off of a model that Thomas Joyner put out about why people die by suicide, there's multiple ways of thinking about this, but this sort of layers this. And a lot of this is intuitive, but I wanted to share it with you just so that you have a better sense of, there's some data to support all of this and some better sense that, you know, these are some things that you can get into. So again, thoughts are images, thinking about wanting to be dead, we talked about before. Joyner's work really kind of focused on sort of this sense of thwarted belongingness, perceived burdensomeness, lack of connection, feeling like you're disconnected to other people, and sort of the interaction of these things that then lead to, as well as an acquired ability or a capability to make a suicide attempt, those things kind of lead to these lethal concoctions where people are engaging in high-risk suicidal behavior or die. So when we talk about belongingness, they feel connected to other people. Most of you are probably not aware there's a national strategy for suicide prevention in this country. We're on our second iteration of that. You know, it's a nice thick book. You can get a copy from SAMHSA, I think, has this book that's out there. It's nice and thick. You can read the whole thing. It's a good thing to read. I can summarize it for you in one word, and that's connection. People that feel connected to other people are more likely to live. We want to know about their connections to other people. So do they feel connected to others? Do they, have someone they can talk to? These kinds of things. Do they feel like they're a burden on other people? It used to be that kids would say, "Oh, I'm just a burden on this person. I can't talk to my mom about this. She's got 5 other things going on. If I talk to her, I'm just going to be a burden on her." Well, we actually know that if we have this conversation with your mother, she's going to feel a whole lot better about talking with you and working with you and problem solving with you if that's what you want, than if we don't talk to her about it and you engage in suicidal behavior. So how do you do these kinds of things? So the kids that are saying, "I feel like I'm a burden on other people," we can't just sort of dismiss it as that sort of adolescent talk. They always feel that way. Not so much. When you're having these thoughts, how long do they last? Some people have these thoughts every once in a while. They come in their mind, they disappear. Other people have these thoughts and they don't go away. And that's, obviously more concerning. Sort of an interesting piece to this, Joanna talks about how strong is your intent to kill yourself, right? Are people really going to give you a valid answer to that question? Because here they're having these fantasies in their mind about getting put into a hospital and all this other kind of stuff. Anecdotally, the data will tell you they'll actually give you some answer to that. Now, their number, if they give you a 1 to 10 or something, or a 0 to 10, 0, I'm not intent on killing myself right now at all, versus 10, I'm going to do it right now as soon as I leave. We can usually tell you that the number they give you is probably about 2 or 3 lower than it actually is, but the point is they will give you a number when you ask the question. What kind of things do we want to know? Let's say they've engaged in past suicidal behavior. What are the things that we want to know about that? How many times have they done this? What did they do? This is, if you have the time to sit down and go through this conversation, this is important information because it helps us with planning for what else can we do, what can be helpful, what have we tried before that wasn't helpful? That's helpful to know. So what have they done before? What were the contexts of that? Who knows? Who knows about it? Data suggests there's like 65 to 200 suicide attempts per death in adolescence. I would venture to guess that most of those attempts go unknown by anybody because many of them never end up requiring medical attention. And I can certainly anecdotally tell you stories of kids that have gone in and overdosed on massive amounts of medication. And basically, I had specifically a girl that I worked with back when I was in training. I can't remember exactly how many pills she took, Wellbutrin and Depakote, and took a whole bunch of it. And her intent was to sleep for a long time. And so when you sat down and talked to her about it, you said, that's quite a bit. I mean, this could be lethal, and tell me about this. She's like, well, I tried to kill myself 6 months ago by taking all this stuff, and I took 30 of this and 35 of that, and I didn't die that time. So I knew if I only took 20 of each, I probably wouldn't die this time. Interesting. That first time, nobody knew about it. She looked really sick at home. She threw up a couple of times. She stayed home from school for a couple of days. And her mom thought she was just really, really sick and maybe had some food poisoning, and that's pretty much the story the girl was giving her. These things happen, people don't know. So who knows about it? What did they do about it if they do know? What happened afterwards? How'd you feel about what happened? Some kids will tell you, I realize now that what I wanted was I needed to feel this or needed to be in touch with that or I needed this or whatever out of it, and maybe I can do that a different way. Other people will say to you, I'm such a screw-up, I can't even kill myself the right way. I worry a little bit more about that. Do they engage in non-suicidal self-injury? Do they engage in cutting? Do they engage in other behaviors where they harm themselves in some way? It's important to know. There's always been this discussion, are they in fact two separate things? The data says, well, they're overlapping. There's some people that only engage in non-suicidal self-injury. There's some people that only engage in suicidal behavior, but there's a good chunk of people that do both. And kind of going between those two things isn't as simple as saying we start with one and then we move to the other. It sometimes goes back and forth. So we want to know about that. And of course, I mentioned before the family history of suicide. Specific plans, what would you think about? Don't be afraid to ask the details of those kinds of things, because if they're talking about something that could happen here in Philadelphia, the one that scared me to death every time I heard it, because it's like, you know, they would jump in front of the L. How do I prevent that, other than keep them away? Well, I can't put them in a hospital for that and keep them in a hospital for a long time. The L's not going to suddenly disappear one day. We can't put their picture up there for everybody to say, listen, these are tricky kind of situations. But other times it's, you know, I'm thinking of, I shoot myself. Do you have access to a gun? Yes, no. And in Philadelphia and in other large cities, access to a gun is not a problem. They might not have one, but they can get one. Means and opportunities kind of leads up to what we talked about. Preparations, kinds of things you've been doing to prepare for it. When might you do this? Again, are they going to tell you the truth about this? You know, if you're having this conversation and you're really getting this depth of information with them, they oftentimes will tell you, I've been thinking, I don't know, I'm waiting for my grandmother to die. She's the most important person in my life. She's very, very sick. She's in the hospital. We're going to keep our eye on that. And one of the unique things that was unique to me is sort of a sense of fearlessness. How afraid are you of dying? You know, I think if I polled everybody in the room and said, how afraid are you of dying, many of you might say, you know, hadn't really considered it, but I might be quite afraid of that. Some people aren't. And how does that play into this whole construct of their wanting to die? Precipitant stressors. I could have put up a list of like triggers, if you will, for youth suicide, but I didn't have 5,000 slides to go up there. And I don't mean that in a joking way, but what I mean is that it isn't necessarily the event happening, it's the perception of an event that might happen. So I may have failed a test, or sometimes it's even worse that I took a test and I think to myself, I probably failed that test, and for a day or so before I get that back, that really hurts. I think there's something really wrong. They feel hopeless. We talked about impulsivity, and of course the presence of psychopathology is sort of the other piece that goes along in all of that. So I'm going to kind of end there, take a few questions. Now, what I was told, because I was moderating back before, if you have a question, please go to the microphone, because the folks that are watching on computers all over the place don't hear a word that you're saying unless you go to the microphone. So I'll stop there and take any questions you might have. There's one over there.
Hi, Mike Federico, ERT. Yep. For a lot of the things that you outlined there in terms of depth and probing, and combining it with the guy's previous talk, do you have a way to do that in a self-rated fashion so that by the time they're sat in front of you, you have something to structure that interview from?
Right. Well, the screening tool that we do use in primary care, that guy's going to talk about more this afternoon. You're talking about more this afternoon? Okay. It asks some of the questions, but the depth, I have a hard time. I mean, again, in clinical trials, and David, you can probably comment on this too, is, you know, we do self-report measures with people and they fill a lot of stuff out. In clinical practice, I think if we're looking for certain outcomes, like I want to see suicidal ideation is decreasing, I want to see depressed mood is changing, I might use some of those measures to assess that kind of stuff. But when I'm getting, you know, information about, you know, this kind of stuff right here, I'm not doing that through a self-report. Let's have a conversation. And I talk with people about that. It takes longer to do that, I recognize that. But the validity perhaps of the information that you get, and certainly the relationship that you're building with that person at that point in time, I think is stronger than simply saying, hey, answer these questions.
You have to do both. You want them to self-report,
right,
and then confirm it and add some structure to your confirmation.
Exactly, so you want to do both.
They might be more self-reporting than sat in front of somebody they may not.
Right, and that's sort of the point that I was making before. You do self-report, you still have to follow up on what they said. So.
Matt, thanks for that very comprehensive talk. I just wanted to comment on something that I think people might have misunderstood.
Okay.
Which is, you had said you don't show people that you're worried. Mm. I think what you meant was don't panic.
Yes, I'm sorry.
Because I think, you know, guys and I know you share this orientation, that sharing that you're concerned about somebody, worried, it's just like you could tell somebody you're angry, and that's okay to do that as long as you're not angry then.
Yep.
It's the same thing. You can tell somebody you're worried about them, you're concerned, and I think that that's real as long as you're not panicking
Right.
when you do it.
Yes.
I just,
No, thank you for that clarification,
Yeah.
because sometimes I say it and then I got to think about what am I just saying. But no, you're right. Don't show them that you yourself are worried about yourself, perhaps, or panicking is the other way of saying it. But it's okay to say, I'm concerned about you, I'm worried about you, right? Sarah?
Hi. Can you talk a little bit about, if you are that second person
Yeah.
sitting down with this kid, how you handle if they do sort of recant and take back what they said initially in disclosure?
Right. Yeah, so they've come in and they've said to somebody else, yes, I've been having thoughts of suicide. They then come and sit down with you and they say, no, I haven't had those thoughts before, and stuff like that. I don't think it's inappropriate to say, this is interesting, because the understanding that I have is that's part of what brought you here to talk with me today. The other approach that you can always take with it is that you're looking for these risk factors. You're looking for some of these things that concern you about them. We don't want to normalize it by saying, listen, everybody that has this, and this going on, a lot of kids feel suicidal in that situation. But you certainly can use, your experience and say, listen, my experience has been that, sometimes when kids have this going on or that going on or that going on, I know you're telling me now that you haven't had these thoughts, and perhaps you said that or didn't say that before, but when you have A, B, and C going on, my experience is sometimes kids do have thoughts about suicide in that situation. Help me understand what's different, for you in that context compared to perhaps somebody else who may have expressed those thoughts, because that then kind of puts them at the spot of, all right, well, maybe if other people have these thoughts sometimes, then I'm not alone in the way that I think about this, and it might be okay to talk to you about it. Or those that truly aren't having these thoughts will then get into, I've got this to live for and that to live for and so on and so forth, which perhaps makes you a little bit more comfortable when you're having that conversation. So, yeah. Would you mind using the microphone? There's a whole audience that's not sitting in this room that can't hear a word that we're saying if we don't. Thanks.
I just had two thoughts. One was your comment about hopelessness, and I actually had an experience with a young adolescent boy who said, it's absolutely hopeless, I may as well die.
Mm-hmm.
And I was kind of proud of myself, because I said, the only time it's really hopeless is after you're dead, because you simply cannot go back.
Mm-hmm.
As long as you are alive, you can make decisions. Once you are dead, you cannot.
Right.
And and he was borderline retarded as well as quite mentally ill, and it was like the light went on, and he went,
Mm-hmm.
oh, and that was that. So,
Right.
And the other thing, I had and again, it was a case that I dealt with a number of years ago in neurology clinic, and a young boy came in with Tourette disorder, because that's the population that I work with, primarily. Mm-hmm. And he was about 9 years old, and looked like he was going to kill somebody as he's sitting on the exam table. So I started the whole little, thing about how are things going, blah, blah, blah. And finally, I said, you look really sad to me. And he said, I am. I said, have you ever thought about hurting yourself? So I did, by increments,
Yeah.
You've ever thought about, oh yeah, I've thought about hurting myself. I said, well, many people think about that, but have you ever thought about killing yourself? He said, oh yeah, I'm going to commit suicide. And I'm looking at his parents going, have you ever heard this before? And they said, no. How are you going to do it? Do you have a plan? He said, there's peanut butter in the house. I'm allergic to peanut butter. I will eat it sometime in the middle of the night.
Mm-hmm.
And we shipped him right down to the ER at that point, because I thought, I don't know how to handle it after that,
Well, but it took the courage of seeing there's something different about this kid than what I would expect, and then asking the difficult questions, and look what happened. You got the answers. Yeah.
That's right.
Maybe not the answers you were hoping for necessarily, but you got the answers. Guy.
I'm going to make a comment and a question, Matt. One of the things we like about our screening tool is that it in fact puts suicide in the context of other risk behaviors. So if you get a yes at a critical level of suicide, you can look at the tool. Is there substance use? Is there family conflict? Is there depression? And it kind of right away doesn't cover everything Matt's covered, but it gives you some context to try to evaluate how serious is this, how severe is this. So it's a nice quality of the tool. I wonder, Matt, if you could say, because I think we've heard a lot the discussions of how far does the primary care provider go
Right.
before they make the referral.
Right.
And that a lot of what this thorough assessment may or may not be what some of these providers are going to be able to
Right.
do. And, we know, I don't encourage primary care providers to do diagnostic work. You don't have the time to fret out, is this bipolar disorder, is this depression, is this, and so I'm just curious how you think about what's enough information to know
Right.
this should get referred versus, it's just an interesting question.
Yeah. So, I presented two different models, sort of this nice abbreviated version, which works fairly well in a primary care setting, and this more expanded version, which, as a primary care provider, if you had the time to do all that kind of work, maybe you'd do it, but most of you wouldn't have that time. And I think there's a couple things that are important. I mean, you certainly want to get into how are things going. You want to get some sense that they're having thoughts of suicide. You can't just stop when they say, yes, I'm having thoughts of suicide. At that point in time, you're in the conversation. You got to keep the conversation going. So you want to know more about, have they done this before? Have they made a suicide attempt before? You want to know a little bit more about what have they done. You want to know a little bit more about, do they have a plan for what they might do, when they might do it, that kind of information. The point is that you're starting to have a conversation about it, and you move into the context of, have you ever told anybody this? Sort of the conversation that you were talking about here that you had with this 9-year-old. Have you told anybody about this before? Because sometimes we have this conversation with adolescents, we've kicked the parent out of the room just to have a normal conversation with the kid anyway, and now we're getting into this conversation. Does your parent know about this? And sometimes the answer is, oh yeah, she knows, or he knows, and sometimes the answer is no. And then I might ask, what do you imagine they might think about this? Because then we have to figure out, we're going to bring this parent back anyway, and we're probably going to end up having some conversation about this. I need to know, what might I expect from them? So you have that conversation. And how do you feel about talking about this right now? Might be an indicator of then you're going to feel comfortable talking to somebody else about it. Have you ever talked to anybody else before about this? And that, again, not just peers or somebody. Have you talked to a professional about this before? And if they have, how'd that go? That's a really important question, because if it went really, really bad the first time they did this, or they didn't feel like they got any better, or something negative happened in their previous experience, we really have to emphasize to people that, maybe this is a different person, different situation. What if you tried somebody else? Because fit is really important when it comes to psychotherapy, I think. But we do that, and then the idea is we really just want to get what would get in the way of you going? Let's talk about that, and we kind of move those kinds of things forward. You don't need to get into all the depth that I talked about there at the end, but you need to sort of get the story and continue enough with the story to feel like, all right, am I worried they might do this if they go home? Well, then that's one response. They've been having these thoughts, but they've been managing it pretty well. How do you deal with this at home? How do you deal with this at school? And you feel like they can get through this, but they would benefit from talking to somebody about it. Then it's, can you imagine talking to somebody about this a little bit and then having that conversation? But again, the goal is to get them, perhaps to see somebody to talk about this kind of work, because we don't have time. We want to, but the other persons, we talked about teams before, right? You bring the mental health community in on a part of your team, and then you feel like, all right, that's one piece of it that I know that this person can do that, I maybe am not expert in. There's a lot of things I'm not an expert in. I call my MD friends and NP friends and all that other stuff and get their advice on that. And I know that in Massachusetts there's a whole other program about how to manage these kinds of things we'll hear about a little bit this afternoon, but I don't know. Hopefully that answers it. I think that's about it. So we're going to take a break now, I think, for 15 minutes. I believe that's the agenda. If someone has the agenda and waves their hand and says, yes, that's right. 15-minute break. So for those of you not familiar with the building, I had to learn this morning. If you need to use the restroom, you can probably turn the camera off. But restroom is all the way down the hallway down there. When you run into a wall, you take a right. When you run into a wall, you take a right, and they're over that way. But we'll be back at 11:15 and with Dr. David Brent. Thank you.